have this means that we need to give a little higher dose, and they were all anyway deficient to start with, so perhaps a higher dose was necessary. This also means that as neonates and infants, we need to continue with our vitamin D fortification and take care of our daily fortification. There's an urgent need for vitamin D fortification of oil as well as milk for all our population. And the third article I found very relevant to our practice was management of neurocystic psychosis in children. This is a recommendation. This study was done by the Association of Child Neurology Delphi Group for Neurocystic Psychosis in Childhood. And Naveen Sankhyal et al. Were Dr. Naveen Sankhyal was the chief examiner for this study. And the conclusions they reached was that the diagnosis of neurocystic psychosis should be based on clinical history and neuroimaging. So no kind of serum study is important for this. And neuroimaging, preferably MRI, but if on CT scan we can demonstrate a scolex, then there is no need to go further to do a MRI. If we do MRI, then we should do a contrast enhanced MRI, which is anyway the modality of choice. If we see a single enhancing lesion, then albendazole therapy 15 milligram per kg per day and 2 divided for 10 to 14 days is recommended. And if there is more than one ring enhancing lesion, then albendazole plus praziquantel in the dose of 50 mg per kg is recommended for 10 to 14 days. And for a persistent lesion, the same dose and duration of albendazole or albendazole plus praziquantel is recommended. Pulse IV steroid should be given to reduce the acute symptomatic edema in children with cysticercal encephalitis. So in this recommendation, the duration of the steroid or the kind of steroid was not written. Carbamazepine or oxcarbazepine are best suited for seizure prophylaxis for those with seizures. However, phenytoin and levetiracetam are other alternatives. In case of neurocystic psychosis presenting with symptoms other than seizures, there appears to be no role for routine anti-seizure medication. So if the child presents with a CT scan or an MRI showing neurocystic psychosis, but has never had seizures or has other manifestations, then there is no role for a routine anti-seizure therapy. For a single ring enhancing lesion, 6 months of anti-seizure medication is sufficient if lesion resolves on follow-up. And those with persistent lesions, calcifications, or multiple lesions require longer treatment duration of at least 24 months. So with this, these are the three articles I reviewed. And the conclusion I have come to is that we have to keep reading. There are many interesting articles. Thank you. Yeah. I think Dr. Hemant Joshi has a question.
No, the NIN is our advisory. They says that fortification and giving nutrients as supplements is a short-term solution to any problem, and it has helped but not eradicated India's nutrition problems. And NIN experts say that improving the firefighting, that we should do them. We should do them. Number two, wearing half pant or working in sunlight is the solution.
Dr. Hemant, your net is very poor, so if you can put off your video, we can hear you clearly.
Yes, I'll do that. Learning. Yes,
yeah.
Can you hear me now?
Yes.
Yeah, so NIN experts say that for nutrition deficiency, fortification, or giving folic acid supplementation is a short-term project. Firefighting, we must do it. But long-term solution is improving nutrition. And in vitamin D, it means promoting half shirt and half pant on equally respectable good dress for all and teaching by example. That is number one. Number two, there is something called as NFHS 5, National Family Health Survey 5, which was conducted from June 19 to December 19 in Maharashtra, all over the India, means before COVID. And it says that the malnutrition has increased in all children. The average height of Indian children has gone down, which means as a nation, we are, and each child is getting less food on an average than they used to get 5 years earlier. So because of overpopulation, we are going bad. I'm just sharing you the national figures. So we need to teach people to have less children and they have them at a bigger gap, or having no second child for at least 1 year or something like that. Thank you. I finished.
Thank you, Hemant. Thank you so much. The only problem is wearing shorts and short sleeves in cold weather. That is why that vitamin D supplementation was in winter. So in summer, we can do that and expose ourselves. But in winter, we wear full clothes and everything and cover ourselves. So that was why.
Agreed. I just told you, I just shared the NIN experts,
Yes, yes.
and let us
Yes, yes.
listen
No,
to you.
I just justified the study I quoted.
Yes. We admire you and respect you on that. Thank you.
Thank you.
And we listen to you.
There was a study done. In that study, they say that only skin exposure or only exposure to sunlight is inadequate to get whatever vitamin D is required for our body. So we should always supplement this skin exposure along with food intake.
Then I will tell you one more extra point. See, vitamin cholesterol is a substrate to make vitamin D, and malnourished children have a low cholesterol. So if the substrate is not there, how will we make vitamin D even if they go in sunlight?
Okay, I think we should not discuss further. We should go to our next speaker, Dr. Kishore.
We need to improve child nutrition and this okay. Agree. So we should do A and B and C. Thank you.
सर मी नेम ऑफ द जर्नल आणि ते जे ऑथर्स आहे त्यांचे नाव टाकले चॅट मध्ये.
Thank you, Anjali madam and Jayashree madam, for such wonderful presentation of journal topics. Now we will move on to our second presentation. World Polio Day is observed on 19th of October, and we have with us today WHO Coordinator and Surveillance Officer, Dr. Kishore Chauhan sir, who will be giving us an overview about polio and rubella. Over to you, sir.
Yes, thank you, Dr. Deepak. Can you hear me?
Yes, sir.
Yes. Okay. Good afternoon, everyone. Can you make me host so that I can share my co-host? Can you make me co-host so that I can share my presentation?
Dr. Kishore, you can share anyway.
Okay, just a minute. No, host a disabled participant screen sharing. Yeah.
Okay, then Vaibhavi has to do that.
Vaibhavi madam, please make me co-host. No, not yet. Done. It's done now.
Yes, sir. Yes.
Yeah, got it. Okay. Can you see the screen?
Yes, sir. Yes.
Okay. Good afternoon, everyone. Today I'm going to present on this 6 topics, but these are very small topics. Only first 2 are important: AFP and fever and rash surveillance. Diphtheria, pertussis, neonatal tetanus, and AEFI surveillance. I'll cover it just in 2 minutes. First topic is polio. This is our last polio case of our country. Ruksar Banu, she's from West Bengal, 13 January 2011. Last 10 years, we did not get polio virus anywhere in the country. Our surveillance system is very strong. In spite of that, we did not get virus anywhere in the country. So our country is free from polio. The WHO has declared India polio free, that is polio eliminated, in 2014. Since then, we have maintained this status. However, the polio is though eliminated from India and many countries, but there are still 2 countries where polio is still persistent. We got large number of cases in last 5-6 years in these 2 countries. in last 12 months, we got total 11 cases from these countries, 7 from Pakistan and 4 from Afghanistan. And if you take a calendar year from 1st January 2021, we got only just 2 cases, one in Pakistan and one in Afghanistan. So the wild virus is very near to us. But there's a very interesting story about this VDPV. We have shifted to BioPV, from TOPV to BioPV in 2016, 25th April 2016. At that time, the type 2 was already eradicated 10 years back. And in 2015, there were no VDPV of type 2. VDPV type 2 also was 0. And then we shifted to BioPV. Along with that, we started giving IPV to cover up the type 2 immunity. But many children did not get IPV vaccine. Initially, there was a shortage for many, 2-3 years, almost many children were not having this vaccine. So type 2 immunity is still not there in few children. But now the supply is good. Now most of the children are getting it. If you look at the history of this CVDPV2, this CVDPV2 is started just with one case in 2016. Now it has spread all over the African country and the Southeast Asian countries. Fortunately, it is not there in India since last 3-4 years. We did not get any VDPV in last 4 years, but it is spreading very fast in these areas. Even if we have eradicated type 2 virus, type 3 virus, but what is the point if the type 2 virus VDPV circulates and it gives the paralysis to the children? So the risk is very, very much high for us of getting the wild polio virus as well as the VDPV in our country, because few children do not have the immunity for type 2 vaccine. This is very important to understand. So this circulation, if it spreads to India, it might spread to in some children, and we may get some cases in our country. For that, we need to be little alert. In case the virus comes to our country, either wild virus or VDPV type 2, we should be able to pick it up fast. For that, they have given the definition of AFP, acute flaccid paralysis. A child less than 15 years presenting with a sudden onset of weakness or floppiness or paralysis anywhere in the body during the last 6 months. We take generally 6 months old cases, or any person of any age in which the polio is suspected. When we rule out all the causes and then nothing is remaining, then it can be reported as AFP even after 25, even after 15 years of age. For that, to make the surveillance more sensitive, to pick up more AFP cases, Government of India broadened the definition of AFP. And they say that consequence of missing the one case of polio are more serious than occasionally including the ambiguous case, especially during the final stage of eradication. That is why we are reporting more and more cases. And they have included many other cases like current flaccid paralysis, history of flaccid paralysis in other current illnesses. Like for example, somebody is having a meningitis and he has paralysis, then that case also can be reported. Borderline cases or sometimes ambiguous cases. We get confused whether to report it AFP or not. That time it should be reported as AFP cases. And even the transient weakness cases. So more and more cases should be reported that is, in case the virus comes, we should be able to pick up as early as possible. And when we report all these AFP cases, these AFP cases are computed against the total population. There's a rate called as AFP rate or non-polio AFP rate. If this AFP rate is more than 2, it means that your search for polio virus is very good. So our AFP rate in our country in 2019, it was 9.3. It is well above the level given 2. And in 2020 and 21, you can see in the red boxes, it has come down to just 4.6 and 3.97 because of corona pandemic. Many patients did not report, did not come out, and we did not get these cases.
We can't hear Dr. Kishore Chauhan. जयश्री ऐकू येते?
नाही ऐकू येत नाही आणि इवन आय एम नॉट एबल टू लाईक सी एनी फर्दर प्रोसिडिंग. स्लाइड्स पण स्टक झाल्यात मला. ही मस्ट बी हॅव्हिंग सम इंटरनेट इश्यूज आय थिंक.
तुम्ही म्यूट वर आहात किशोर सर.
अनम्यूट करा.
हा आता मॅडम मागचं ऐकू आलं का मॅडम 3-4 स्लाइड्स?
नाही सर. दोन
नाही,
No,
last
because
slide
your
ऐकू नाही आले सर.
एक slide. हा.
Just a minute, just a minute. This slide you have seen? No.
we can't see your slide.
Now you can't see my slide?
No.
No, sir.
Okay. I have to reshare it again. Just a minute, ma'am. Can you see now?
Yeah.
Yes, sir.
Okay.
Could see till here.
Okay. You had seen this slide?
Yes, sir.
Yeah, this one? This one. Okay. This one? No. Okay. You can hear me, madam? So our AFP rate, that the number of AFP cases we report, it is computed against the total population. It is a population-based indicator. It should be well above 2. And in VVCMC, our AFP reporting is 8.6. It is well above 2, and it is very good. It indicates that our search for poliovirus is very good in VVCMC. They have given the definition of eradication. For consecutive 3 years, if there is no polio case, then we declare it as it is eradicated. So now the virus is there in Pakistan and Afghanistan. Once they become 0, after that we will have to still continue with the AFP surveillance for 3 years, and then it will be declared as a polio eradication. My next topic is measles and rubella elimination. It was decided to eliminate measles and rubella by 2023. This is a goal given to me. Madam, can you hear me? Dr. Deepak, can you hear me?
Yes, yes.
Okay.
Yes, sir.
Yes. So though the goal of elimination of measles rubella was given for 2023, we may not achieve this, but it will extend by 2 years again. Right? If you look at the measles incidence, you can see the large number of cases occurring in the Central Africa and the Southeast Asian countries. This is where we get all measles cases. Last in 12 months, we got 84,000 cases of measles in all these countries. If you look at the rubella incidence, you again see that the rubella incidence is common in the Central Africa. And if you look at all the countries, they are shaded. All these shaded countries mean where the rubella vaccine is being given. They have started a rubella vaccine program. But you can see the Central African countries where the rubella incidence is more. Those are not shaded, means the rubella program is not started there. If you look at the number of countries in the world, we have 194 countries in the world. Out of them, you can see in the last yellow boxes, measles has been eliminated from 81 countries and rubella has been eliminated from 93 countries. So around 50% countries, they have eliminated the measles and rubella. If you look at India, what is the status of measles cases? In 2020, we got 5,502 cases. And in 2021 till date, we got 3,125 cases of measles. These are confirmed cases. And as far as rubella is concerned, last year we got 1,400 cases all over the country. This year we got 980 cases of rubella in our country. What about VVCMC? In our corporation, you can see in the yellow boxes, VVCMC, this year we have got 2 measles cases in Vasai corporation and 4 rubella cases in our corporation. So 2 measles and 2 rubella. Last year we had 13 measles cases and 1 rubella case. It means that in our Vasai Virar corporation, still the measles and rubella virus is still present. We know the locations of these viruses in the corporation, and we have already instructed those medical officers to look at the immunization coverage in those particular pockets where these cases have been located. So these are the strategies to check the viruses in that area. So we are near to elimination of the virus, but we will still get few cases for 1 or 2 years. For eradication, for elimination of measles and rubella, they have given us 2 indicators. They say that your non-measles, non-rubella rate should be more than 2. Should be more than 2. It is a population-based indicator. The number of fever rash cases we report, and then we compute it against the population, and the rate should be more than 2. The second indicator, they said MCV2 coverage, that is a second MMR dose. If the coverage should be in the population, it should be more than 95%. So what is the status of that? First of all, that they have given the definition of fever with rash or suspected measles or rubella case. Any person with fever and maculopapular rash, or a person in whom the clinician suspect measles and rubella infection. For example, the patient is coming for the post-measles rubella complication after 1 month. So that time he doesn't have a fever in the maculopapular rash. So when the clinician says that it is a post-measles or post-rubella complication, so that can be taken as a fever with rash case. And these such cases up to 90 days old cases we can report in our data set. These are the non-measles, non-rubella rate. I mean the cases which are coming negative. So in India, in October 19 to September 20, the rate was 0.93, and we want more than 2. And last year, last 12 months, October 20 to September 21, the non-measles, non-rubella rate is 1.09. It is well below the 2. I mean, we are still a little far away from this, the elimination of the measles rubella. What is the status of this rate in our Vasai Virar Corporation? Last year, we have reported 76 cases. This year, we have reported up till now 85 cases. So last year, the rate of this NMNR was 2.7. This time it is 3.7. It is well above 2 per lakh. So this is on this front, reporting of AFP cases and reporting of fever rash cases, we are doing excellent job in our corporation. And thanks to the group which we have, Madam has formed, Anjali Madam, Vishu Madam, and Dr. Barod, they have formed this group. And that group is doing excellent work. Even my seniors from our organization, they also appreciated the reporting of the system of our group. And what is the immunization coverage in this? There are 2 indicators they are set. In non-measles, non-rubella rate should be more than 2, and measles 2 coverage should be more than 95. But that measles 2 coverage is less than 95. It is just 89% in Vasai Virar Corporation. This is all our monitoring data. So, and we have located the health post also, where it is less, and we are targeting on those particular health centers. In those areas, this coverage is very less. So we are trying to improve the coverage in those areas. Lastly, the DPT, diphtheria, pertussis, tetanus surveillance. These are the cases of diphtheria. Diphtheria has gone down very much, but there are still pockets in the country, like UP and then Karnataka and Gujarat. You get a lot of diphtheria cases. In 2019, there were 3,200 cases, 2020, 1,800 cases, and 2021, we have 828 cases in the country. Simultaneously, along with the AFP surveillance and the fever with rash surveillance, the diphtheria, pertussis, and neonatal surveillance are also going on. It is also picking up. Now, this is pertussis. We had 900 cases in 19, in 23, 90 cases, and into 2021, it is just 278 cases of pertussis in the country. And about the maternal and neonatal tetanus, has gone down very much. It is, and we have got the certificates also that this neonatal tetanus in India has gone to the elimination status, and we have got the certificate from WHO in 2015, and they say that your rate of neonatal tetanus cases is less than 1 case per 1,000 live birth. When we achieve this status, it means that neonatal tetanus is at a very, very low level, and we have to maintain that level. Of course, this disease cannot be eradicated because the cycle of the organism is in the animal. So this cannot be eradicated, but whatever elimination status we have achieved, we need to maintain by immunizing all the pregnant women in ANC and giving the tetanus vaccine along with the pentavalent to all the children. So neonatal tetanus cases, we have got this year only 44 cases in the country. So this number is very, very small, and we are going to maintain this, and it is happening very, very well in our country. So lastly, I would like to appeal, please report the AFP case below 15 years of age, fever with maculopapular rash of any age, suspected diphtheria, suspected pertussis, and suspected neonatal tetanus. Thank you very much. Thank you.
Thank you very much, and such lovely data, and it's like recent up till date. Thank you so much, Dr. Kishore.
Thank you, madam.
There's
Dr.
just one.
Kishore,
Yeah.
Yes.
I would like to congratulate team of Dr. Kishore because recently I got one patient from Ranu. The intern has come with the patient of measles for blood collection because they didn't get the blood. So I think your team is really serious about collection of a patient, following them up and collecting the blood also, because I have never seen such dedication of, I think, AFP and fever with rash team. So congratulations, Dr. Kishore and your team.
Yes, sir. Thank you, sir. Thank you very much.
It's really good, but do we check serum IgM levels?
Yeah, for
the
serum
fever
IgM,
rash?
they have collected blood.
Yes.
Yes,
For measles.
for serum IgM, the intern was accompanying the patient from Danu.
Okay, acha. That's
And in
great.
AFP, they collect stool samples.
Yes, madam.
Yeah, they definitely they do.
Yes. Thank you, madam. Thank you.
Thank you so much, Dr. Kishore.
Thank you very much, Dr. Kishore sir, for telling us the current status of such deadly diseases which are vaccine preventable, and also guiding us about reporting of cases of diphtheria, pertussis, tetanus, polio, and fever with rash. Thank you very much, sir.
Thank you, sir.
Now let's move on to our third talk, which will be by Dr. Pradnya Gadgil madam. She is a pediatric neurologist from Kokilaben Ammani Hospital, and she will be presenting a case of Gaze palsy. Over to you, madam.
Thank you, Dr. Sarani. Good afternoon, everyone. As usual, it's a
afternoon.
great joy to see familiar, friendly faces. Will I be able to share my screen?
Vaibhavi? Vaibhavi, you may have to make Pradnya also a co-host.
Yes, madam, done. You can
Yeah.
share your screen.
Yeah.
Thank you. Thank you. It's a very small presentation. It's a interesting, intriguing case that happened just after Ganpati, if I'm not wrong. And it's a nice illustration of how the kind of mistakes that we would make. I mean, and that refers to me, but also a nice illustration of how working together can help solve these unusual clinical presentations. Can you see my PowerPoint?
Yeah.
So this was one of my old patients, a 10-year-old boy. So the past medical history is that he has underlying epilepsy. Possibly the epilepsy syndrome was thought to be something called Douzet's syndrome. Douzet's, as we all know, is a mimic of Lennox-Gastaut, but a much milder version of epilepsy, not an epileptic encephalopathy like Lennox-Gastaut. So he had, when I saw him quite a few years ago, he was referred by Dr. Vivek Rathod. I just realized when I was looking at my notes. So he had drop attacks and an occasional generalized convulsive seizure. And EEG showed that he has photosensitivity. So this sort of sets up the stage for diagnosing as Douzet's. It's an electroclinical syndrome. But he was seizure-free since 2016 on a small dose of valproate, just 600 milligrams per day of valproate, and he was seizure-free. And that sort of shows you how this is not an epileptic encephalopathy. If it was Lennox-Gastaut, in which also you get drop attacks, you get generalized seizures, the EEG is much more abnormal. Usually Lennox-Gastaut is a medically refractory epilepsy. Anyway, so I'm digressing here. So he had this epilepsy, which was well controlled. He had mild intellectual disability, hence he had academic issues, but that was all static, and the parents were doing therapy, remedial, and life was going on. So suddenly he had a new symptom, and I think I got a call from the dad or the hospital. He went to Dr. Gokarn's place, right? If I'm not wrong. So got a call that this is a patient who's come in and he has eye deviation to one side. Now, given the context that this is a kid with epilepsy, my first reaction was that, oh, this must be he's conscious and he's able to speak. So given this, my first differential was that this is a focal seizure. Now, what's a background? Why would you just call a sustained eye deviation to one side in a conscious child with acute onset a seizure? Because you get occipital onset seizures, occipital lobe seizures, especially kids who have occipital epilepsy due to whatever reason, the benign one or the symptomatic one. When you get occipital seizures, that's all they get. Their eyes deviate to one side. They're fully conscious, they're able to speak, and they're very prolonged events. So whoever I spoke to on the phone, and forgive me, I'm bad with names. So I said, look, this could be a seizure, and why don't you give him lorazepam? So they gave lorazepam, and please do jump in. I'm a little bit sketchy on this since I don't have it written down anywhere. I think Dr. Gokarn, your assistant.
Dr. Manisha, yeah, Dr. Manisha,
Dr.
you were
Manisha, that's right.
communicating with.
Yeah.
And we gave midazolam initially, and then you said 20 mg of levetiracetam.
Right. And that brought no joy, right? There was no
No.
change in his symptoms at all whatsoever. Right.
Yeah.
Right, absolutely. And so then, given that we gave 2 good anti-epileptics in good doses, and in a child where epilepsy is well controlled, then this makes it, clinically speaking, unlikely to be a seizure. Of course, rare things do happen. Can this be a seizure which is refractory to treatment? Yes, for sake of argument, it can be. So I think you also got an EEG done.
Yeah,
very
we
quickly.
got an EEG done, and we also did the serum levels of valparin, which were
got that.
yeah. EEG also didn't show any focus.
Correct. And the reason, the indication, and again, I'm just discussing this because they're learning practice points for all of us. The EEG, the main reason to do an urgent EEG is to rule out a subclinical seizure, which is just going on and on. Again, this can rarely happen. We've certainly seen cases, and the history of underlying epilepsy was completely clouding my judgment on the phone. And I thought, so what if the midas hasn't helped? This could still be a seizure which is going on. So maybe an EEG will help us, conclude whether this is a seizure or something else. And of course, if he's subtherapeutic, then that might explain it on his valproate. So I requested for the valproate levels as well. So it's incredible how very quickly all this got done there. So I'm just going to show you the video. I got this video. I think Dr. Manisha sent me this video the next day. Can you see the video? Can you see the video, or do I screen share?
No, it's not playing.
No, I'm just about.
Yeah.
Yes, we can see.
Can you see what he's doing here? Please look at the eyes. Can you see? I don't know if you could appreciate this. He's turning his head to whichever direction he's being asked to look at. His eyes aren't moving. He's turning his head. Please have a look at this again. This is a classic sign. So up and down is still okay, but he's moving his head. He moved his head so that the eyes actually are looking in the front, and he's able to obey the command that's given saying, look in the front. So his eyes aren't moving, he's moving his head. His eyes are sort of stuck to his right side. So he's not moving so he didn't need to move his head a lot when he was asked to look towards his right. But when asked to look towards his left and the front, it was mainly head movement that helped him look either way. Do I need to play the video again, or is that point?
Clear.
Yeah, thank you. So I saw this video and I realized, oh my God, what a fool I am. I've completely misjudged this whole thing. This is actually what we call conjugate gaze palsy to the patient's left, towards his left. So I promised Dr. Gokarn I'll talk a very tiny bit about gaze. So what is conjugate gaze? Conjugate gaze is when your eyes are moving together in whichever direction it is. And so if they can't together move in a certain direction, and it could be either side or upwards or downwards, then we call it a conjugate gaze palsy. Now, conjugate gaze palsy is a focal neurological deficit. It's just like you get an acute facial palsy, or you get acute hemiparesis, an acute ataxia in adults, acute slurring of speech. whatever you might want to call acute ophthalmoplegia, acute sixth nerve, that's something that we see on and off. So point is, a conjugate gaze palsy in whichever direction is a focal neurological deficit. And the lesion can be in the cortex, either the frontal lobe or the parieto-occipital junction, depending whether you're talking about smooths or smooth pursuits or saccades. It can be in the brainstem. Midbrain is one notorious area in adults where it gives rise to a vertical conjugate gaze palsy because of tumors and infarcts. Or it could be in the connecting fibers. It could be, for example, in the PPRF or the MLF. But basically, point is, it's an acute onset focal neurological deficit. So the first differential that would come to mind is this a stroke? Has he had an ischemic infarct, or has he bled? So given this completely change in our working hypothesis, he got shifted to Coquilabin for urgent management. So he came on a Sunday evening, and I think we did a MRI straight away. And all we found was, I don't know if it's projecting, that's why I've put a red square. This is the flare image, eggshell, and this is the dorsal pons where my mouse is. And you can see on the left side, there's this white lesion. Is it seen?
Yeah.
So this was very, very subtle. If you had a cursory glance at the MRI, you would miss it. Of course, we had the benefit of saying conjugate gaze palsy is the presentation, so look at the brainstem very carefully, as much carefully as you would look at the cortex. He had this very subtle lesion in his dorsal pons. This wasn't an infarct. There was no diffusion restriction. We still did an angio. This is not a bleed. So we discussed this, and this was very likely an area of demyelination. But this is odd. All he has is a horizontal gaze palsy to the left, and it's ipsilateral, right? I mean, he couldn't see to his left. His eyes were sort of stuck onto his right side. They couldn't move together to his left. And this is a lesion in the left dorsal pons as well. So again, very, very briefly, there are multiple syndromes that you can get, what we call dorsal pontine syndromes, where infarcts or bleeds or hemorrhages, whatever, would give rise to a set conglomeration of symptoms. Very likely what he had was this. There is something called a Foville syndrome, in which you get a unilateral lesion at the dorsal pontine tegmentum, and it causes facial palsy, gaze palsy, hemiparesis, because remember your descending fibers are there. And it's not only motor, but you get a hemisensory loss as well, and you get INR. But in our patient, his luck or whatever, he only had ipsilateral horizontal gaze palsy. So like I said, our working diagnosis was that this could be demyelination. Given demyelination, then you have to look at other places in the neural axis to see, is there any other evidence of demyelination? So his spinal, we screened his spine. There was nothing. We had already looked at the brain. We sent on NMO and MOG antibodies because that is something that's known, especially MOG. Now these are immune-mediated causes of demyelination which can keep recurring. So the management would be very different. So always do send these antibodies if you have a case of demyelination involving anywhere in the neural axis. So not GBS, but spine or brainstem or the brain, not peripheral nerves. So we had sent this. Later on, the reports came and they were normal. ANA as a screening, really speaking, because this was such an odd presentation, just a horizontal gaze palsy, tiny area of what looks like demyelination, and then he was really okay. So we gave him steroids. We didn't give him the full dose. We only gave him 10 milligram per kg for 5 days. And then this is how he looked later on. Can you see the video, right? See, he is able to now, without moving his head, actually look to his left. Do I need to play it again or? So can you see his eyes have now come to midline without him having to move his head? And this was on day 3 of steroids.
Still his left eye is not
Does he have left 6 palsy also in the video?
Yeah. So that is what we thought as he was recovering. That's a great point. I can't see who made that point.
Jagdish.
Yeah.
Bade.
Yeah, that's a great point. So dorsal pontine lesions can also give rise to a 6th nerve, ipsilateral 6th nerve. So very likely he had a horizontal gaze palsy to his left, along with a left 6th nerve palsy. Absolutely, yeah.
The 6th nerve palsy did not recover.
No, he's so this was in hospital actually. He's come to me for follow-up, and now he has completely normal gaze. He's the horizontal gaze has recovered, the 6th nerve has completely recovered. I'm sorry, I don't have a video of that in OPD, but he's fully recovered. We are going to repeat a scan in 2-3 months because he's such a unusual presentation. You know, a very firm thrust of the whole thing. The demyelination looked half-hearted. The clinical symptomatology was half-hearted. So though he's improved, we'll probably just, we don't normally, in demyelination, we don't need to keep repeating scans if we think it's an isolated event. But in his case, we have planned to repeat a scan in another couple of months.
How long did you give the steroids, Pradnya?
5 days. And then oral tapering for about 3 weeks, just coming down on it quickly. So normally this is unusual. Normally I give 30 per kg. You know, I remember I had an old Irish professor and she would say, Pradnya, you want to treat, don't give half dose of ceftriaxone, don't give half dose. You give the full dose or you don't. Like, you know, so we usually would give 30 per kg, but his whole presentation was so odd. And it didn't progress. Like it took a good 24 to 36 hours before we surmised that this is demyelination and started steroids. And he did not worsen in that time. So that also makes you wonder whether this could just be self-limiting and he could have gotten better by himself. Like, you know, it's not necessary that every demyelination needs to be treated as well. But then you have a focal deficit, the whole anxiety surrounding it. Hence, we gave a 10 per kg. Otherwise, it should ideally be 30 per kg.
Nice. Something so unusual. Dr. Kishore, would this qualify for acute flaccid paralysis?
Yeah,
Yes.
yeah. I think we did. We informed them, I think.
Yes, ma'am.
Madam, did you continue oral steroids after giving 3 doses of methylprednisolone?
Yeah, just for 3 weeks and tapered it off.
Oral continuation, maintenance.
No, just
Tapering
for a
off.
taper. Just for a taper.
Tapering off.
Yeah.
Taper off.
Yeah. So
And what are
20,
the
55 and stop.
What are the chances of relapse? This or some other, at some other site of demyelination?
So that is why you look at the antibodies to see whether you can prove that a given patient has a chance of relapse. But if the antibodies are negative, then the chance of relapse, and again, look, these antibodies have come in the last 5 years. You know, we didn't know NMO and MOG before this. So overall speaking, a single, what we call a CIS, you know, a clinically isolated syndrome, the first demyelination, overall the chance of relapse is very, very less. I don't think we have percentages yet because the MOG spectrum is still evolving, but overall very, very less. But now that we have the antibodies, I think we should check these 2 antibodies in the blood, because then if they're positive, then I wouldn't have stopped steroids. If these antibodies would have come positive, then especially MOG, then you would have continued steroids. If NMO was positive, then I would have added another immunosuppression and then slowly taken off the steroids.
This Douce syndrome is a genetically predisposed syndrome.
Yeah.
So for the second child, we have to do genetic counseling.
No, so it's not inherited. It's not it's typically de novo mutations. All the mutations are also not clearly defined. So it's not like I don't know, like a Draves, where you have SCN1A and this mutation, and you have some more SCN2A, 2Ds, which will cause that the febrile seizure plus sort of a phenotype. No, so the genes aren't well characterized or well identified, nor is it inherited. So no.
If it is MOC positive, how long would you continue steroids?
So MOC positive is the better one of the two. The NMO is the nastier relapsing demyelination, and of course the big brother is the pediatric multiple sclerosis, MS. So the MOG, the current recommendations are, and these will keep changing, I think, but just the last set of guidelines which has come through, we are now giving steroids only for 6 months, only steroids. We are not actually going on to azathioprine or rituximab or a steroid sparing agent, because the recommendation is you give steroids for 6 months, and then they are fine. The chance of relapse is less, and that is what we are seeing. If you're interested, I'll show you a couple of my mock patients at some point. One of my first patients was 7-8 years ago, when I never heard, the report came back from Spain, and I had to look up saying, "Ye kya hai?" Like, mock kabhi suna nahi hai. Hardly any publications were coming out. And that chap actually had so I did not give him any immunosuppression, stayed stable for about 3-4 years before having a mild relapse. So MOG is a much milder disease. NMO is a nasty disease, comes with optic neuritis. Both of these can come with optic neuritis. So I have patients who are blind, apart from the myelitis and the brain lesions. So NMO, you have to maintain a very tight control with respect to the immunosuppression. We end up giving rituximab very often, and if that's not tolerated, then we go on to the others. But MOG is the simpler, the less the more benign one of the two.
So maybe we should invite Pradnya again next month for presenting those cases.
I think a couple of cases have come from, I think Tanu got a kid who was sent with meningitis, fever and meningeal symptoms. So the MOG's phenotype is expanding. It's very exciting, actually.
Thank you so much, Pradnya. That was lovely.
Thank you. And thanks for the collaboration. So I was actually sitting in Goa when this patient came with eye deviation, but it was great how, I mean, I did my mistakes, but eventually he got managed. So thank you.
I wish we need not have disturbed you, but we had to.
Thank you.
Thank you, Pradnya madam, for presenting such an interesting case. Now we will move on to our last presentation. Our last speaker for the afternoon is Dr. Rajesh Joshi, sir. He's a consultant pediatric endocrinologist from Wadia Children's Hospital. And he will be telling us about plotting of growth in children. Over to you, sir.
Thank you. Good afternoon, all. Can you see my slides and can you? Okay. So today I would be talking on growth charts and how to plot on the growth charts. So growth charts are the anthropometric measures which are collected from large number of children in a cross-sectional manner, and percentile curves are prepared from these anthropometric measures, and of course they are used to monitor the growth. I did not tell this august audience about the importance of growth monitoring, but just to tell you a few facts that it is a very good screening tool to diagnose a chronic systemic endocrine or nutritional thing. Yeah, and it helps to identify these problems much before the parents can come to you and tell that my child is not growing. So it is a very sensitive indicator of a child's health. And the very first growth charts were by ICMR in 1956 to 65. But they were irrelevant later on because the anthropometric measures are also taken from children with a lower socioeconomic strata where malnutrition was also there. And as you know, in malnutrition, there can be stunting, and you cannot normalize that stunting into a growth chart. The next growth charts that were available were by Agarwal et al. And the anthropometric data was from the affluent urban children. And these growth charts, the data was in 1989 to 91. So this is a very old data, almost 20 years old. And these were the K. Agarwal growth charts, which many of you must have used previously. Yeah. So what are the growth charts that we should use now, having known that the K. Agarwals are old data? So the IIP recommends that in children from birth to 5 years of age, we should use the WHO MGRS growth chart. They are called as the growth standards. They are prescriptive because it defines how a child should grow when they receive a good nutrition and health. So it represents good growth, that is a norm which one should aspire to. So this data was collected from a study, yeah, from almost all continents except Australia, and India was part of that. And it was a prescriptive approach, which means that exclusively breastfed children, yeah, who had appropriate complementary feeding, so they received optimal nutrition in living in an optimal environment where they did not have much infections, where their parents did not smoke, and they received optimal health care with immunizations and pediatric routines. They were the only ones who were selected for this growth chart, and it represents a optimal growth or the thing to aspire for. So these are the WHO MGRS growth charts, which many of you must be using. And the blue stands for boys and pink colored charts stand for girls. And the IIP, what it has done is it has correlated all the three parameters. On the upper side, you can see these centile lines for length. These are the centile lines for the head circumference, and these are for the weight. So this has been correlated into a single chart. And if you see these lines, take for example, boys charts, these lines on the upper side. Yeah, you can see these two black lines. Yeah, and then there is a different line, which is a yellow line and a red line. So these growth points below these yellow and red lines are abnormal. So what this yellow line indicates is the third centile. Yeah, and what the red line indicates is the first centile. So any child who is below the third centile is called as a child who is stunted, and one who is below this red line or the first centile is called a child who is severely stunted. Yeah. Similarly, you have these and a yellow and a red lines for the weight also, where you will call it as underweight and severely underweight. Remember, the x-axis is age in months and not in years. And it is from 0 to 60 months, that is till 5 years of age. And on the y-axis are the numbers where you plot either the weight, you plot both, all the three things, weight, head circumference, and the length or the height of the child. Now you will also come across charts, the same charts, where you will see the centiles. Can you see this 97 centile, and into bracket is written +2. Then there is 50th centile, into bracket is written 0. Then there is this third centile, into bracket is written -2. So what are the things that is written in brackets? And it brings lots of confusion to some pediatricians when they see these numbers also. These are nothing but the Z scores. Yeah, and what are the Z scores? So when you have a normal distribution, take for example, we want to know in a population what is the normal height of a man and a woman, adult man and a woman. So we collect the data. So this data is distributed in a normal distribution in a bell-shaped curve, yeah, and it clusters around the mean, which is over here in the center. You can see the 0, that is the mean. Yeah. And the total area under this bell-shaped curve is 100% or 1. Okay. So you can see on one side that there is -1, or this is a -1 Z score, and on the right side it is +1 Z score. Then you can see -2 Z score and +2 Z score. So this, when you correlate all this data of adult men and women, then the average or the mean say comes to 174 for men and 136, this 156 for women. Okay, so this is the mean, and -2 standard deviation on both sides are 95% of the population lies on this side. Yeah, so for a adult man, yeah, the -2 standard deviation is 158, and for a woman it is 147. So whenever you define any parameters, say like short stature, or you define say a head size or whatever, you say that whatever is less than -2 standard deviation is abnormal. Yeah, for a height less than -2 standard deviation is called as a short stature. So in an adult man, if he is below 158, then he will be called as a short. Yeah, and a woman less who is below 147 will be called as a short. And when you take this -3 standard deviation, it indicates severe degree of an shortness. Yeah, which you can see here is 149 and 142 respectively for a man and a woman. So if we take this 0 Z score, yeah, that corresponds to 50th centile over here. Yeah, -2 standard deviation corresponds to 2 standard deviation below the mean or the third centile. So the third centile is -2 standard deviation. The first centile or the red line, yeah, that is the first standard deviation. Similarly, the same thing is for weight and for the head circumference. So I think this concept of Z score is now clear to all of you. So now, what are the growth charts that we should use for children between 5 to 18 years of age? So these are called as descriptive growth charts because they were prepared from a population which was thought to be growing in the best possible state of nutrition and health. And they represent how children are growing rather than how they should be growing. The MGRS is a prescriptive, the best thing that environment that a child would grow. So that was a prescriptive. This is a descriptive growth charts, and this is this publication was there in 2015, where the data was collected from 9 different places from India. Almost 87,000 children were taken, and these growth charts were prepared. And one very important thing in these growth charts, which was not done previously, say in Agarwal growth charts, was all abnormal weight for heights. You know that in the population, obesity is increasing. Yeah. So if you take the say obese child's weight as a normal and you make a growth chart, that will give you erroneous results when you plot and interpret the growth charts. So all abnormal weight for heights were removed from these growth charts, and these are the growth charts which are available to us from 5 to 18 years of age. This is for boys and this is for girls. And on the x-axis, the age here is in years. And in between 2 years, it is divided into 12 parts. So you can plot the growth of the child for each month in these growth charts. Yeah. And here again in the growth charts, whatever is less than the third centile of the height will be called as a child who is short. Now what the IP is done is, instead of keeping 2 different growth charts, say from 0 to 5 or from 5 to 18, the IP has correlated these and growth charts together. So now you can get a growth chart from 0 to 18 years of age, and you can plot on one growth chart. But here the problem is, in the first year or 1.5 years, it is very difficult to plot on this, because this is, as you can see over here, it all looks black and it is difficult to plot. So in those cases, you can plot on the 0 to 5 growth charts. So this was about a plotting of a height and weight. But if we want to know in a given population or in a given child, yeah, whether that child is undernourished or he is obese, Yeah, what are the growth charts that we are going to use? So remember the growth charts which I showed you before. Yeah, the weight below the third centile may not always mean that the child is undernourished. Okay, you have to use a WHO weight for length or WHO weight for height growth charts as shown over here to know whether the child is an undernourished or is obese. As shown over here, the x-axis is the length in centimeters and the y-axis is in the weight in kilos. So this is a age independent and a criteria or age independent chart. Yeah. So again you can see over here the lowermost red line is first centile or -3 standard deviation. Then you have this yellow line which is third centile or -2 standard deviation. Then you have the 50th centile and you have the 99th centile or +3 standard deviation. And a child who is above the 99th centile as shown with a red dot over here will be called as a child who is obese. Yeah, so this is below 5 and this is normal. A child's weight for height which lies between the yellow and the red line, which is between the first and the third centile, will be a child with moderate acute malnutrition, and a child below the first centile or -3 standard deviation would be a child with severe acute malnutrition. So what do we do in children above 5 years of age? So there we use the IIP body mass index growth charts. And as you can see over here, the lowermost line is the third centile. Yeah, then the fifth, 25th, yeah, fifth, 50th centile, and above 50th centile, what you can see is a 23rd adult equivalent. Yeah, which is a red, and then you have a yellow line, which is a 23rd adult equivalent. And how do you calculate the body mass index? It is by a formula weight in kilos divided by height in meters square. So any child's body mass index, which is this red dot, which is below the third centile, will be called a child who is undernourished or malnourished. The one who is above this line, yeah, but below the 23rd adult equivalent will be said to have a normal body mass index or is not malnourished. A child who is between the 23rd adult equivalent, this orange line and the red line in between this, would be called a child who is overweight, and a child who is above the 27th adult equivalent will be called a child who is obese. Yeah. So remember always that use either weight for height or the BMI index to know whether the child is undernourished or the child is obese. So now we have this in a new growth charts. It is not new, actually it was in 2015. But if you compare it with the previous Agarwal charts, was there a difference? Yes, there was a difference. It was found that at 18 years, a average boy's height, that is at 50th centile, a boy was taller by 2.8 centimeters, and at 97th centile, he was taller by 5 centimeters. And for girl, the similar figures were 0.8 centimeters and 2.6 centimeters. So there was a secular trend, yeah, which made the children or boys and girls having a little height which was on the larger side, and this is because of the improved nutrition. If we compare our growth charts IIP with other countries, yeah, where do we stand? If we compare with the Asian countries, then our heights are almost similar with other Asian countries. However, if we compare it with the Caucasians, say UK, Europe, yeah, or USA, we see that their children are quite taller than our children, to the tune of 5 centimeters they are taller than our children. So uh, so this tallness is possibly because the total height that they gain during puberty, our children gain a little less height than what the Caucasians gain. So these are other growth charts. These are the CDC growth charts, not from our country. So one must remember that we should not use these growth charts, yeah, to plot our children, or otherwise we may falsely get many of our children as a short stature. Yeah. These are called as the height velocity charts, and these are again the height velocity charts of a Caucasian child. Do we have height velocity charts for our children? So yes, Dr. Vaman Khadilkar has recently he has published these height velocity charts, yeah, for our children. So how do we plot a height velocity? Yeah, so for height velocity, we should have two growth points, say two height measurements, which is ideally 12 months apart or at least 6 months apart. Take for example this boy, yeah, at the age of 9 years he was 119, and at the age of 10 years he was 125 centimeter. So he has grown 6 centimeters in a year. How do we plot on this height velocity chart? Yeah, so he has grown 6 centimeters, yeah, from 9 to 10 years. So we plot it at 9.5 years mark. So this is 9.5 years, and this is 6 centimeters. So you can see over here, I have plotted him with a red dot, and it is on the 75th centile. So this growth velocity is normal. So what is the normal growth velocity on this growth chart? So remember, on a height velocity chart, the normal velocity is about 25th centile, yeah, and not about third. That one must all remember, that on a velocity chart, if the child's velocity is above the 25th centile, then we would say that he is growing normally or his height velocity is normal. If it is below 25th centile for consistent time, then we would say that his height velocity is not normal. So we also have growth charts for children with other diseases also, which cause short stature. For example, Down syndrome, Turner syndrome. Now, if you see this Turner syndrome growth charts, you will see this gray shaded area which is there. So what is this gray shaded area? So this is a normal girl, how she grows. The gray shaded area shows how a normal girl grows. And below this, all these lines from third centile to say this 97th centile is how a Turner's girl grows. Yeah. So Turner girls, as you know, that they have short stature. So I have plotted one Turner girl's height on this growth chart. So you can see over here, these are the growth points, red dots. So she was growing at 50th centile, and suddenly at the age of say 10 years, her growth started faltering and she came down almost one centile line down, was touching to the second centile. So if you additionally plot on the Turner's growth chart, and if they falter on that, yeah, you can know possibly this girl has other problems in addition to Turner, and Turner's also have hypothyroidism and celiac disease, because of which they may not grow. So she was here diagnosed with hypothyroidism, was supplemented with thyroid, and you can again see that she grew again and she reached to what her previous line was, that is at 50th centile. Here was the time I gave her growth hormone, and you can see that she has crossed the centile line up, yeah, and she has come to her 75th centile. But our goal is, since this girl has got a mid-parental height up to 50th centile, she should at least cross this third centile. So plotting on a Turner syndrome growth chart, in addition to the normal growth chart, does help in these special circumstances. So we also have a growth charts for achondroplasia and also for Noonan syndrome children, which also cause growth faltering. So what are the recommendations of growth monitoring? So this is one slide which you all must keep in mind, and you must follow this to the T. So at birth, weight, length and head circumference with a stretch penile length is taken. In the first year, when these children come to you for a immunization, that is the time you must in addition take the weight, length and the head circumference, and after that every 6 monthly up to 8 years these anthropometric parameters must be taken and must be plotted on the growth chart. After 8 years of age, you can take all these anthropometry every yearly. So what are the steps in growth monitoring? So the first thing is to know the correct age of the child by asking the birth date and then taking accurate weight and height. So all of you must be taking this anthropometric and measures very accurately. But one thing I must tell you that please buy a stadiometer, yeah, in your clinic. It does not cost more than 1,500 rupees. Yeah, this is a more accurate way to know the height of the child. Yeah, after 2 years of age, yeah, when a child can stand, yeah, the height is taken in this way so that the heels, the buttocks, the back of the scalp touches to this vertical board of the stadiometer. Then this moving board is brought down. A chin tug is given so that an imaginary plane running from the eyes and the tragus is parallel to the ground. Then this moving board is brought down, it touches the scalp, and the height must be taken. I again repeat, it must be taken up to zero point 0.1 centimeters, up to 1 millimeter accuracy. One must take the height. And when you take these anthropometric measures, then you must plot on the growth chart. Okay, what are the things that you look on a growth chart? When you plot, the first thing that you look is what is the height and the weight centile. What does it tell you? What is the status of this particular child in comparison to population? For example, this is a boy whose weight is 23 kilos and the height is 115 centimeters. So you can see he is below the third centile. So this child is short for the population. So he is a short child. What is the next thing that you see? You see whether this child is growing like his parents. Yeah. So you see for the familial effect. And how do you see for a familial effect? Is by taking a mid-parental height. Okay. So take for example, this is a boy 9 years with a height of 117 centimeters. And you have plotted his growth point over here. You can see it is just below the third centile. For the population, he looks to be short. Father is 157, mother is 150 centimeters. How do you calculate mid-parental height for a boy? It is mother's height plus father's height plus 13 divided by 2. So you add 157 plus 150 plus 13 divided by 2 comes to be 160 centimeters. So we have plotted with the arrow on the right side, yeah, at 160 centimeters. So this is the target height. Can you see over here? It is plotted with the arrow. Okay. And then there should be a target height range or mid-parental height range. So 8 centimeters above and 8 centimeters below, you draw two lines. So this is the target height range. What does it mean? So though this child is at the third centile, if he grows normally, if his height velocity is normal, he would grow along this line and he would end up at his target height range anywhere between these two lines. Okay, so this is the other thing that you should plot. Then the next thing, so what you do is you draw a imaginary line from the lowermost mid-parental height line, and you can see that the child's height is lying above this. So he is within the mid-parental height range. So possibly this is a short child of short parents, possibly a familial short stature, but you should not only stop here calling it as a familial short stature, you must confirm by taking his height again after 6 months and seeing that his velocity is normal. Take example of these two children with same height. Yeah, and can somebody answer which is the child that worries you most? Is it the first or the second? They are of the same height.
The first one, there is a weight plotted.
Sorry, why the first one?
The plotting.
They are of the same height.
Okay.
Yeah, they are of the same height. Same age, same height.
Because in the second, the weight and height are going together.
Yeah, so the weight also was the same. Weight also was the same. So remember, when you say the weight and height are going together,
Mid-parental height.
exactly. Remember, the
Much
first
below.
thing which I told you was, even if you see that the weight is below, it does not mean that he is malnourished. Okay, so here, if you see the mid-parental height, the second child is well within the mid-parental height. So possibly he is a short child of the short parents. But if you see the first case, yeah, the parents were tall, and this is a mid-parental height, and the child is way below the mid-parental height. So this is a pathological short stature. This may be a familial short stature, which is physiological. Okay. The third thing that we look in a growth chart, if a child is short or if the child is obese, is there a nutritional effect for this shortness or for obesity? How do we know that? Take for example the same child. Yeah, his height is over here, the weight is over here. Will you call this child as malnourished? So the weight is below third centile. Will you call it as malnourished?
His weight for height would be normal if plotted.
Exactly. So remember, when you want to know whether the child's nourishment is normal, never look whether this is below the third centile or what. Always calculate either the weight for height for children less than 5 years of age or body mass index for children who are more than 5 years of age. And this was the body mass index 14.6 kilos per meter square, and this body mass index was at 25 centile, which is absolutely normal. So the cause of shortness in this child is not a nutritional cause. It is not a chronic illness. It is not that he is eating less. It may be an endocrine cause of the short stature. Remember, whenever you plot on a growth chart, plot only with a dot. Do not put a cross around it, or do not make a cross over it. Yeah, these are not the right way to plot the growth charts. Only a dot is what is required. Recently, IIP has also brought out pediatrician-friendly growth charts. Now, what do you mean by pediatrician-friendly growth charts? They are the same growth charts. They are not different. However, many of the pediatricians say that doing a mid-parental height where they have to do a calculations, doing additions, dividing, and all these things is very cumbersome, is in a busy practice. Even doing a body mass index, yeah, where division is there and then squaring of the height in meter square is there, is also very cumbersome in a busy practice. So what they have brought out is a easy way to find out the body mass index, especially for children who are above 8 years of age, because obesity is usually a problem in this age group. And also they have brought out simple way to calculate the mid-parental height. So how do we do that? So here is on the left side upper corner is for the knowing whether this child is in a normal weight, underweight, overweight, or obese. For example, take this boy who is having a height of 145 centimeters and a weight of 35 kilos. So this is 145, this is 35. Where they intersect, you have a point. Yeah, UW means underweight. Any point below this is underweight. OW is overweight. Any point above this is overweight. Any point above OB is obese. So since this child is lying between UW and this, he is having a normal body mass index. Take example of this child with 147.5 centimeters height and a weight of 45. He is clearly above this yellow line of overweight. So he is an overweight child. And a third child with 160 centimeters and 70 kilos lies above the red line. So he is an obese child. So you need not do any calculations, divisions, and just by knowing the weight and the height, yeah, in a child above 8 years, you will be knowing whether the child is having obesity, underweight, or whatever. Yeah. What about the mid-parental height? So over here you can see that the father's height, yeah, and the mother's height, which is 156, and here is the father's height. Yeah, they are joined together. Yeah, and this intersects at the 50th centile. Yeah, so if you know the father's height, you know the mother's height, you join it, see whether it is intersecting, and plot it on the growth chart on the right hand side. Yeah, so this is the mid-parental height. So here again, you need not do any calculations like adding mother's height plus father's height, subtracting minus 13, divide by 2, just draw a line, and you will come to know at what centile is the mid-parental height. Okay, so the take-home points from this presentation are: number one, consider all growth measurements. Consider everything, plot everything. Do not just plot length and weight. Plot the length, plot the weight for length. Yeah, if the child is above 5 years, plot the body mass index. Yeah, head circumference. Collectively will allow for a complete picture of growth. Number two, growth pattern over time is more important than one single measurements, which means that according to the IIP recommendations, you must start plotting growth right from birth till 18 years of age as per the recommendation, and you must see the trajectory, how the child is growing. If he is following a 1 centile line, that is good, is growing normally. Yeah, it is preferred to interpret weight in perspective of height and not alone. As I showed you, only weight below 3rd centile may not mean that the child is malnourished, especially if the child is also having short stature. So you must use either the weight for height for children less than 5 years and the body mass index for children more than 5 years to know about the state of nourishment of the child. Weight for height in children less than 5 years and body mass index more than 5 years are better parameters to define wasting, undernutrition, and obesity. And the concept of severe acute malnutrition or moderate acute malnutrition on weight for height growth chart, usually use it beyond 6 months of age. Yeah, because before 6 months of age, you will not get a very good picture on the weight for height growth chart. And crossing 2 percentile lines in 6 months in children less than 1 year and in 1 year in children more than 1 year always is pathological. Immediately investigate the child. And a growth pattern that remains flat is usually a growth concern and requires further assessment. Thank you for your kind attention.
Fantastic presentation, Dr. Joshi.
Thank you very much.
There was so little we knew.
Sorry?
There was so little we knew, and we just thought we are still starting and only planning height and weight. And some are not even doing that. So yeah. And just one correction, the stadiometer costs 2,500 and it's available online.
Yeah, no. So there are different stadiometers with different cost. So I was just saying yesterday on Amazon and Flipkart, there are few stadiometers which cost 1,500. As you rightly said, they cost anywhere from 1,500 to 2,500. And the best and the most sturdy stadiometer, which is of Sikha, yeah, it cost somewhere around 15,000, but it is worth investment because the other stadiometers, though they are good, they are meaning if they are lying in an area where many children are there, they are playing with those stadiometers. The uppermost part, yeah, many a time gets broken and you have to buy a new one.
And even Dr. Hemant Joshi was saying that now those growth charts which you mentioned with the ready-made mid-parental height and BMI charts are available. So I think they will be available for download, and Dr. Joshi has said he will,
Yeah, but remember, if you don't have those charts also, now, if you have a calculator or your mobile, yeah, within 30 seconds you can do all those calculations.
Yeah, there are apps
meaning,
which are available.
Meaning if they are also not available, you can use your calculator for doing all those calculations.
Yes.
Ma'am, it is available on IIP website for download.
Yeah. Okay. Yeah, Dr. Hemant Joshi is going to print them. Hemant, you wanted to say something?
या तुमचं झाल्यावर मी माझ्यासाठी चार्ट छापणार आहेत. आपण ब्लॅक अँड व्हाईट झेरॉक्स केला तरी ₹1 पडतो, पण आपण सगळ्यांनी एकत्र छापले तर प्रत्येक चार्ट आपल्याला ₹1 और लेस मध्ये पडेल.
करून घेऊ ना.
हा, तर आपण सगळे मिळून कोणाला किती चार्ट पाहिजे त्याचे ₹1 पर चार्ट प्रमाणे पैसे माझ्याकडे जमा करायला सांग सगळ्यांना, आणि मी एक्सेस पैसे परत करेल. म्हणजे मला पैसे नको आहेत.
नाही, we'll get it done.
Because I'll have to print 40 to 80,000 charts at one time.
Yeah, we'll do it.
आपण सगळ्यांचं म्हणजे ऑल ऑफ अस, त्यामुळे ना जिल्ह्याची क्वालिटी सुधारेल ग. आणि इफ दे कॅरी इट होम ना, दे बिकम एम्पॉवर्ड, सो दे विल सी दॅट दे फील इट. आणि डिजिटल तर करायलाच पाहिजे, दोन्ही करायला पाहिजे. ओके.